Selamat pagi. Good morning, everyone. My name is Wong Ming Gui. I'm a pegawai science microbiology from Jabatan Pathology. The title of my topic is Laboratory Investigation in Dengue Infection. If you haven't noticed it, this is a recording and I won't be taking any question during the presentation. But you are welcome to forward your question to unit quality and I'll aspire to answer them to the best I can as soon as possible. As a clinical scientist, my focus will be on microbiological properties of the dengue virus and the related diagnostic tests. I will also touch on some other laboratory tests related to the management of dengue patients. My rank reference are CPG on management of dengue infection in adult, third edition, 2015, and management of dengue in children, second edition, 2020. We'll first look at the family tree of the dengue virus. Taxonomic classification of viruses is very complicated. Different textbooks may give you different classification scheme. The classification scheme that I'm presenting here is the one that is generally accepted by most biologists in the world. Under this classification scheme, a dengue virus belongs to the family Togaviridae. Togaviridae are single-stranded RNA viruses with a lipid envelope. Togaviridae family is further divided into two main genus, i.e. the alpha viruses and the flaviviruses. Under an older classification scheme, genus alpha viruses and flaviviruses were known as Group A and Group B arboviruses. Arbovirus is a shortened form of arthropod-borne virus. The name is outdated, but the knowledge is still relevant to us. Dengue virus falls under the genus flaviviruses. A close relative of the Togaviridae family is the Untitled family. If you go through the members of both families, you will see a list of very nasty viruses, such as the yellow fever virus, West Nile virus, the famous hantavirus, and a lot of encephalitic viruses. Taxonomy is a very dry subject. Masa saya student dulu pun, subjek ini paling boring. But let me share with you a very interesting story about Nipah virus. Nipah virus outbreak bermula pada hujung tahun 1998 in Ipoh, Perak. I believe most of you are still in primary school at that time. I was a student myself in University Malaysia in the year 1999. Pada masa itu, pig farmers, penternak babi di Ipoh mendapati babi mereka mati selepas menunjukkan simptom-simptom respiratory dan encephalitis. 28 spesimen telah diuji dan 4 didapati positif Japanese encephalitis (JE). Drastic measures were taken. Mana-mana babi yang menunjukkan simptom akan dibunuh. Tidak lama selepas itu, tiada lagi babi yang sakit. So our local authorities thought that the JE outbreak among the pigs has been contained. Unfortunately, not long after that, many people turned up sick in Negeri Sembilan. They were very sick with very high mortality rate, as high as 40%. Tapi mengapa di Negeri Sembilan? Bukanlah wabak JE itu di Ipoh? Rupa-rupanya, penternak babi di Ipoh telah melarikan babi-babi mereka ke Negeri Sembilan. That's why the Ipoh outbreak appear to be contained. Seorang pakar dengue pada masa itu, a professor of virology from University Malaya, linked these two events and concluded that the new outbreak in Negeri Sembilan was also a JE outbreak. JE is transmitted by vector mosquitoes. So, aktiviti fogging pun dilancarkan. Semua ladang-ladang dan kampung-kampung pun difogging setiap hari. However, in my opinion, the mosquito must be racist kerana nyamuk ini cuma target orang Cina sahaja. Both in Ipoh and Negeri Sembilan, almost 100% of the patients coming down with illness were Chinese and adult. How come? This does not make sense. We know that JE mainly affects unvaccinated children. Many healthcare workers also suspected that this was not a JE outbreak, and especially a junior virologist from University Malaya, Dr. Chua Kao Beng, was very certain that this was not JE. Dr. Chua has a theory. He thought that this must be caused by a different pathogen that had jumped species from pig to human. Chinese were affected because they were the pig farmers and they came into close contact with sick pigs. Adult and vaccinated children were also getting sick because they were not immune to the new pathogen. Dr. Chua took some samples and flew to CDC Atlanta to prove his theory. Why Atlanta? University Malaya tidak pandai kah? Anyway, sure enough, he discovered a new virus, Nipah virus. Why was it called Nipah virus? Because it came from Kampung Sungai Nipah in Port Dickson, Negeri Sembilan. So the moral of the story, jangan salahkan nyamuk. No lah. The majority of arthropod-borne viral infections in human result in simple febrile illnesses that cannot be distinguished from other common viral or bacterial infections. That's why we should appreciate the taxonomic complexity of these viruses and always keep an open mind when seeing these cases. Okay, let's go back to our slides. To recap, dengue virus is an arthropod-borne virus, penyakit bawaan nyamuk. It has a single-stranded RNA inside a lipid envelope. It has a complex ecology. Its reservoir is mainly small mammals like monkeys. It is transmitted by mosquitoes. The mosquitoes don't just carry the virus on its body. The virus is kept in the mosquito's family from generation to generation because of trans-ovarial passage from insect to larva. So even the mosquito larva carry the virus. Human is just an accidental host that prefers small mammals like monkeys. There are 4 main serotypes of dengue virus: Ns1, Ns2, Ns3, and Ns4. So, from the Nipah story, I hope that some of you will be interested in doing research because there are still many areas of interest to study. Recently, in the year 2013, a 5th serotype was announced. The viral sample was actually taken in the year 2007 and it took us scientists 6 years to confirm that this is a new serotype. No new serotype of dengue virus had been discovered for the last 50 years. Imagine the excitement when the discovery was confirmed, and all of this happened in my homestead, Sarawak. Furthermore, the sample came from a clinical dengue case in Hospital Umum Sarawak. So be open-minded, and someday you might just make a discovery too. The data from this slide is a bit outdated, but it shows a very clear pattern. Ns1 and Ns2 serotypes had overtaken Dengue 3 and Dengue 4 serotypes and has become the main circulating serotypes in Malaysia. In terms of geographical distribution, dengue serotypes Dengue 1 and Dengue 2 are usually considered a metropolitan, whereas Dengue 3 and Dengue 4 are sylvatic, kawasan pedalaman. If we study the geographical distribution of dengue serotypes in Malaysia, we can see some patterns. You can find Dengue 1 as the main circulating serotype in Pantai Barat, Semenanjung Malaysia, and Sarawak. Dengue 2 pula di hampir semua negeri di Semenanjung Malaysia, and they are the major serotype in Johor and Terengganu. Dengue 3 in Pahang, and then Dengue 4 in Kelantan and Sabah. The pattern is quite clear antara serotype bandar dan luar bandar. Looking at dengue incident rate, it has been increasing for the past 10 years, and it was highest in the year 2019 at almost 400 cases per 100,000 population. The good news is that your seniors have been managing dengue cases quite well, and the mortality rate has dropped to below 2 mortality per 100,000 population. From now onwards, we'll see how good is your management, your dengue case management compared to your seniors. Hopefully even better. That's why we have this workshop. Here we can see that Selangor and Kuala Lumpur has the highest number of dengue cases. No surprise there. The incidence rate in Selangor and Kuala Lumpur was well above the national rate. I'm not sure why Kelantan ranked number 3, but Johor was number 4. So be on the lookout. Maintain a high index of suspicion for dengue. The number of dengue cases has dropped since 2020 after the COVID-19 pandemic. It dropped even lower this year. Some researchers have suggested that the decrease in dengue cases was related to our movement control orders, MCOs. But relationship was difficult to prove. However, I wanted to point out that every year we have a cycle of dengue cases. Jumlah kes dengue biasanya meningkat pada awal tahun dan pertengahan tahun. Pattern ini tidak berapa jelas pada tahun ini karena jumlah kes berkurang, but it is still there if you look carefully. Now, let's move on to the next slide on the cause of dengue infection. I believe that you have seen this slide from other speakers. My focus is on the laboratory parameters, changes, and the serological profile of dengue infection. The hematocrit will increase drastically during the critical phase, while the platelet count will decrease. The hematocrit and platelet count will slowly return to normal during the recovery phase. On the other hand, the virus antigen is detected early in the infection, then it will become undetectable when our body starts to produce antibody against the infection. We will study the dengue serological profile again later. For now, we'll first look at the disease monitoring test offered by our laboratory. Dengue laboratory tests are divided into two main types. First, the diagnostic test, And secondly, the disease monitoring test. We'll look at the disease monitoring test first. White cell count or WBC count and platelet count usually decrease as the disease progresses. There is no correlation between disease severity and platelet count. This is a level 3 evidence. Most importantly, platelet count does not predict bleeding, and this is based on level 1 evidence, the highest level. You may be tempted to focus on the platelet count, but remember this: platelet count is not predictive of bleeding. On the other hand, rising hematocrit is a marker of plasma leakage when the patient goes into critical phase. You can find the normal range for hematocrit in most textbooks, but for Malaysian, the median value is 46% and 42% for male below and above 60 years old, respectively, while for female it is 40%. These values are from local studies of level 2 evidence. Apart from FBC just now, other disease monitoring tests include liver function tests, LFT, and renal profile (RP). These tests are usually done daily and monitored closely, especially in critically ill patients. Other tests like coagulation profile, lactate, and blood gases are done as clinically indicated. Cardiac markers such as troponin and/or CKMB are specialist tests. You need to consult a specialist before you request this test. All this is summarized in this table, which you can find in the CPG. The take-home message is this. Number 1. Baseline HCT and WCC should be established early during the first visit in all patients with suspected dengue infection. And number 2, serial FBC and HCT must be monitored closely as dengue infection progresses. Dengue infection is difficult to differentiate and diagnose clinically. That's the main purpose of a diagnostic test. A dengue test will confirm or exclude a clinical diagnosis. Dengue diagnostic tests are divided into direct or indirect dengue tests. A direct test targets the dengue marker on the virus. The markers could be the virus itself or its RNA, the genetic material inside the virus, or protein molecules produced by the virus. One of the main protein markers for detection is the Ns1 Antigen. NS stands for non-structural protein. In other words, direct dengue tests detect the presence of virus in the patient's specimen. If we look at the virus model, the viral particle has many structures, such as the membrane, envelope, and capsid. These protein structures are targeted by the antibodies produced by our body's immune system. Antibodies against dengue virus are produced only in response to a dengue infection, and these antibodies are the markers detected by indirect dengue tests. The main classes of antibodies detected by indirect tests are the IgM and IgG antibodies. Due to this fact, we have higher confidence in our diagnosis when the result of the direct testing is positive. We have proven the presence of the virus. Some of you may wonder, why don't we just use the direct testing and forget about the indirect testing? The reason is the viral particle, its genetic materials, and the viral antigen are only present for a short period of time, usually during the first 5 days of infection. As such, we have a very small window of opportunity to detect and diagnose the infection. This is why we needed the indirect testing. Antibodies, especially those of the IgM, is only present in an active infection. So, its detection is a very conclusive evidence. In addition, IgG antibody is produced by our antibody in large amount that the test is very sensitive and it persists for a long time. Thus, we have a bigger window of opportunity to detect and diagnose a dengue infection. In a laboratory setting, tests are usually classified according to the method or principle behind the test. Viral culture or isolation will detect the active viral particles. This is the ultimate gold standard in any microbiological testing. The evidence of the infectious virus. As mentioned earlier, viral particles can only be detected early in the infection, usually day 1 to day 5. The culture process takes a long time, up to 21 days, and it is only offered in AMR, MKAK, Makmal Kesehatan Awam Kebangsaan Sungai Buloh, and UMNC, University Malaya Medical Center. So, this is not a suitable test that can help in the clinical management of dengue virus. RT-PCR can detect as well as serotype the virus. The information on the serotype is of great importance to epidemiologists. It has the same limitation as culture, in that the virus genetic material is only detectable from day 1 to day 6. This test is offered in AMR or the MKAs, Makmal Kesehatan Awam. The closest one to us is in JBE and UMNC. For your information, we are one of the sentinel sites for the National Dengue Surveillance. This means that we will send dengue positive specimens to MKA for serotyping using RT-PCR, but that is for epidemiological purpose, and so again, RT-PCR is not suitable for us in clinical setting. Serological testing is the method of choice for hospital setting. Serological testing can be lateral flow immunochromatography, ICT assay, or ELISA, enzyme-linked immunoassay. Most of the rapid dengue test kit uses the ICT method. However, the current rapid test kit that we are using here uses fluorescence immunoassay (FIA) method. Serological markers for dengue are Ns1 Antigen, IgM, and IgG antibody. We call the test kit a rapid combo test if it is capable of detecting all three markers simultaneously. Rapid combo test kit is good, but sometimes we don't want to look for all three markers. Maybe we just want to look for Ns1 antigen or IgM only. That's why here in HSNI, we offer the serological test separately. Ns1 antigen as one test and IgM or IgG antibodies as another test. It is more economical this way. As for ELISA, we used to offer both IgM and IgG, but nowadays we are only doing ELISA IgM. ELISA test is conducted in batches, so the test is not done routinely. ELISA test is usually performed as a special request from physician. For your information, our current rapid test using the FIA methodology is a semi-quantitative test, but we don't include the titer value in our report. This table summarizes the way we report our test findings. For a quantitative test, there is usually a cutoff value. Any value below the cutoff value is considered negative, and any value above the cutoff value is considered positive. However, IgG has a different way of reporting. When our test detected IgG but at lower titer, we'll report it as negative. We'll only report it as positive when IgG is detected at high titer. This makes it easier to differentiate past dengue infection from secondary dengue infection, because in secondary dengue infection will produce a high amount of IgG antibody. This is not the general practice. So, if you were in other hospital, please confirm with the laboratory on the way they report the result for IgG antibody. I am presenting this slide to help you understand the technology behind our test. Firstly, we'll look at the ELISA platform. Here, I'm showing you the dengue IgM capture ELISA. In an ELISA assay, the reaction happens in a microtiter well. In the microtiter well, there's a solid phase and a liquid phase. The solid phase is the bottom of the well, and it is initially coated with anti-human IgM antibody. This solid phase will capture all the IgM in the patient's serum, and then we add in the dengue antigen that has been conjugated with a marker molecule. The marker molecule will react and produce detectable changes such as color or fluorescence, depending on what marker was used. The intensity of the color changes correlates with the intensity of the reaction, meaning that the more intense the color changes, the stronger the reaction, which also means that there are more IgM in the sample. The solid phase, the liquid phase, and the conjugated markers can be designed to detect all sorts of molecules in the sample. On the other hand, the lateral flow architecture is slightly different, but the basic principle is similar. The solid phase is the test line and control line with antibodies fixed on the surface. The liquid phase is actually the strip itself. The analyte will react and combine with the conjugated marker to form antigen marker complex and flow through the liquid phase via capillary flow action. When it passes through the test line, all the antigen markers complex will be captured on the test line. Excess conjugated markers that didn't react will continue to flow to the control and will be captured there. The antigen marker complex will produce color change, and that is what we see on the strip, a line. Due to the differences in the design, the intensity of the color usually does not correlate with the amount of antigen in the sample. This is the main difference between ELISA and rapid test kit. However, the current rapid test kit that we are using has a different design, and the manufacturer claims that the intensity of the test line correlates with the amount of antigen in the sample. That is why our current test kit is said to be semi-quantitative. Now let's re-examine the dengue serological profile again. The vertical y-axis is the amount of antigen or antibody in the patient's serum. The light blue curve is the dengue antigen. It could be the virus particle or the Ns1 antigen protein. The red curve is IgM antibody, and the green curve is the IgG antibody. The horizontal x-axis is the day of illness. I put an arbitrary line here, this dark blue horizontal line, to denote the limit of detection for our test. Level above this line will produce a positive result, and vice versa, level below will be negative. Tests with lower limit of detection is said to be more sensitive and will pick up more positive cases. In a primary dengue infection, the Ns1 antigen will be detected early, usually before day 5 of illness. That is point A here. At point B and C, the disease has progressed further, and we are able to detect IgM followed by IgG in the patient's serum. This is where I would like to introduce the concept of seroconversion. Let's say the test missed the IgM detection at point B, maybe due to sampling or testing error, or the test is less sensitive, i.e. has a higher limit of detection. In this case, the result will be IgM, IgG negative. But if you retest the patient again a few days after point C here, this time you will get the result IgM negative, but IgG positive. Your patient is said to have seroconverted from negative to positive for IgG. If you rule out sampling and testing error, seroconversion like this, from negative to positive, usually means that the patient has an active infection. If we move on to secondary dengue infection, the window for detection for Ns1 antigen is here. But the window is very small and easily missed. Maybe you took the sample late, or the test is not sensitive enough. IgM antibody is usually not detected in secondary infection, but IgG antibody will be produced in large quantity and very fast. So at point D here, you will only detect IgG antibody, Ns1 antigen negative, IgM negative. It is difficult to conclude that your patient is having secondary dengue at point D. If you were to repeat testing your patient at point E, maybe this time using an ELISA or a semi-quantitative test like what we offer here, getting a positive IgG with very high titer will confirm your diagnosis of secondary dengue. On the other hand, if point E is the first testing of your patient and you get an IgG positive with very high titer, your patient is highly likely to be having secondary dengue infection. My explanation just now may be a little bit confusing, so let's look at this summary table. For an acute dengue infection, Ns1 must be positive. IgM can be either positive or negative, and if IgM is positive, you don't need to look at IgG. However, if Ns1 is positive, IgM is negative, but IgG is positive, you have a secondary dengue infection. On the other hand, if Ns1 is negative, IgM is negative, but IgG is positive, you need to know the titer level of the IgG. If it is very high, or if it increased fourfold after successive testing, or if your patient seroconverted from negative to positive, then this is a secondary infection. Dengue patient management is similar for both primary and secondary infection, but patient with secondary infection usually has a worse prognosis, so be aware of this. Another way to look at this, the interpretation of dengue lab result, is this way. If the day of illness is less than 5, Ns1 is the most important test. Positive means acute infection, but a negative result cannot rule out dengue. And if clinically indicated, you should repeat IgM after day 5. After day 5 of illness, a positive IgM means a recent dengue infection. Meanwhile, IgG would support the IgM result, but be on the lookout for secondary infection. If all the results came back as negative and it correlates with clinical finding, then the patient does not have a dengue infection. In the previous slides, I have mentioned about clinical finding a few times. Clinical findings is very important. Your clinical observation is very important. It will determine if a repeat testing is justified or not. In the laboratory, we don't like to test the same patient repeatedly. Why? Because the first thought is that you don't trust my result. If you don't trust my result, then don't send your sample to me. But if you present your case well and the repeat testing is justified by clinical finding, we are happy to cooperate with you and do your test. So next time, don't send an incomplete lab request. Itu cari gaduh lah tu. I reject your request. Anyway, let's look at the mathematical principle behind all this. My IgM and IgG test has a sensitivity of 97.7% and specificity of 99.5%. We all know the acronym SNOP and SPIN. This is the general rule of thumbs on clinical testing. Highly sensitive test, negative result, rule out the disease. Highly specific test, positive result, rule in the disease. But it is never that simple, right? If only medicine was that simple. Let's use a scenario. Let's say your patient has fever for more than 5 days and tested negative for Ns1 Antigen and IgG. Since your patient has been ill for more than 5 days and your boss said to always have a high index of suspicion for dengue, and together with your supporting clinical findings, you concluded that your patient has an 80% probability of having dengue when you order the test. Using the theorem of Bayesian probability, we calculated a 8.46% probability of having dengue infection even when all the test results came back negative. That's why your boss says cannot rule out dengue, and our CPG and dengue guidelines ask for repeat testing in this case. Bayesian probability is very useful in clinical testing, but it requires a bit of effort to understand its principle. I have a link here to a YouTube video explaining this Bayesian probability. Those of you who are interested to study this can go here and learn about it. According to our CPGs, for postmortem case, you should repeat dengue testing at the time of death. If serology is negative, but you still suspect dengue, you can go for viral isolation or RT-PCR. The specimen of choice is tissue sample, especially from the liver, spleen, and lymph nodes. Bone marrow should be in EDTA and CSF as well. Viral isolation can accept all these specimens in solid form. But for RT-PCR, we prefer fluids, and paling senang, just send blood. In congenital dengue, the preferred test is either Ns1 or IgM or both. No need to go for the high-tech choice like viral isolation or PCR. Just send blood for Ns1 and or IgM. A word of caution here. Serological dengue tests have been shown to cross-react with other flaviviruses like Japanese encephalitis (JE) and non-flaviviruses such as malaria, leptospirosis, toxoplasma, syphilis, etc. etc. Sometimes patients with connective tissue diseases such as rheumatoid arthritis (RA) also produce false positive result. The manufacturer of our dengue test has assured us that false positive is a very rare event, but still always correlate laboratory results with clinical findings. Here in HSNI, you can request a dengue test using this form, Laboratory Request Form for dengue and flavivirus. We prefer this form because the important clinical information needed is already stated in the form. You just have to follow the instruction on the form and fill in completely. Of course, you can still use the general pathology form, PRPAT 301, but we may reject your request due to incomplete clinical history. As for specimen type, we prefer blood in plain tube. The plain tube can be either this gold cap tube with gel inside. This is what we call a gel tube. The proper name is actually SST, Serum Separator Tube. This should be your first choice, or you can use this red cap tube if you can't find the gel tube. At the moment, we promise to deliver your test result within 2 hours upon receiving your specimen. We aim to shorten the waiting time to 1 hour. There's another plan in the pipeline. We are planning to offer dengue test as a point of care testing (POCT) at emergency department soon, very soon. This will further reduce the waiting time to possibly half an hour, hopefully. And so, with that, I would like to end my talks with very big thanks to you, and especially the Unique Quality as organizer. As this is a recording, you can forward your questions to Unique Quality and I'll try to answer them as soon as possible. Thank you.